Hello, my name's David Pook. I'm a medical oncologist at Monash Health. Thank you for the opportunity to present our survivorship project today. I'm presenting on behalf of Vicky, our nurse practitioner in oncology, Tegan, who's our clinical nurse consultant in adolescent and young adult cancer, and Tracy and Jody, our SMICS project coordinators. Our project is a testicular cancer survivorship project with our aim to optimise long-term follow-up of these patients. Testicular cancer follow-up is quite complicated and challenging. It obviously particularly involves young males, aged between 20 and 39. It's got a very high cure rate, which is excellent, but it means that the scope for mistakes is low. These patients all should do well. So following up according to guidelines is a real challenge. And as you can see on the right of the slide, the follow-up guidelines are really complicated. If they have a type of cancer called a seminoma, then you can see the top follow-up is reasonably simple, but they have a non-seminoma down the bottom, it's much more complicated. And so it's easy to make a mistake. Also, this population of men are less likely to attend appointments, mainly because they have complex psychosocial needs. Some of them are quite immature if they're early 20s or late teens. They're often in junior roles at work. It's difficult for them to get time off to attend appointments. So the aim of our project is to try and improve the adherence to these complicated guidelines. And then we also want to better identify psychosocial issues in patients with localised testicular cancer who come through our clinic. Specifically, the objectives are to increase the proportion of on-time visits with the correct investigations being performed when the patients arrive. We want to identify more psychosocial issues in patients using screening tools. We also want a way to be able to identify all patients who are more than a month overdue for appointments so we can take steps to follow them up. And we would also like to collect local data on relapse, adherence to guidelines, and then use of psychosocial support. So the methods. We've chosen REDCap as the database for our project, which has got some pros and cons. It's very secure. It's already in our hospital, which is obviously very important. It also has the ability to use logic, but the logic can be tricky to design. And the way that we plan to use the logic in this database is to have the database measure the time from the visit, when you've got the patient in front of you, to the time that the cancer was removed, and be able to calculate which surveillance visit the patient is presenting to, and then which investigation should be done at that time, and from that then guide the clinician. And specifically, if, for example, a CT scan is missing, the database will need to advise the clinician that they need to get the CT done and then bring the patient back to clinic. So first the design, and we're most of the way through that, which is excellent. The next will be testing of the database. In that phase, we will continue our current workflow in clinic, but we will start using the database by senior clinicians, as well as our practice nurses, really looking for mistakes in the database. Is it telling us to bring the patient back at the wrong time? Once we're happy that the database is working correctly, that it's not making any mistakes, then we would like to implement the database throughout our clinic. And the database will be used by all clinicians in the clinic, and it's designed in such a way that it's simple to use. It tells you what you need to do, and it will also auto-generate some notes which can then be pasted into the clinical record. So this shouldn't be a burden on clinicians. It should be something they want to use. We also would like to then have nurse-led follow-up of testicular patients rather than just relying on medical oncology. And then finally, the audit phase means that we will then be able to measure things that we've never been able to measure before. So what's the adherence to the surveillance guidelines? What proportion of patients are requiring psychosocial supports? In order to try and plan what sort of support's required. We'd like to be able to benchmark our relapse rates against published data to see, are we doing as well as other hospitals? And finally, we may even be able to suggest potential modifications to current guidelines if, for example, a number of patients are presenting at a certain time with relapses. Thank you for your attention.